Modern imaging workup techniques, which, when, and for what? In the past few years, the volume of breast imaging modalities have grown exponentially, and thus implementing sound practice has become a real challenge. It's no more mammography and ultrasound in breast imaging, but with mammography we have the tomosynthesis and the contrast. With the ultrasound we have the Doppler, the elastography, and the ABIS, and with the MRI we have the diffusion and the spectroscopy. And definitely the challenge in breast imaging is not only to diagnose the underlying cause behind breast symptoms, but it is how to apply the best practice to do so. And to be able to do so, we must be able to choose the most appropriate imaging modality, and we must be also able to correlate what we see in this imaging modality with the clinical data and with imaging findings in other imaging modalities. And so in this lecture, we're going to try to sort out some the answers for some commonly frequently asked questions concerning the use of the modern imaging technologies. The first, it was what is the most appropriate modality to be used in screening, and which modality should be used for complementary screening. When should we recommend for contrast mammography, and when should we recommend for tomosynthesis? Contrast mammography and MRI, which is right for whom and under what conditions? And lastly, when do mammography and ultrasound still take an upper hand over modern diagnostic imaging modalities?
To answer these frequently asked questions, when should we use which modality and under what conditions? And again, for the second time, we will have our wonderful guide tour guide, Luke, to lead us in this tour.
And now we'll follow the traffic lights with Luke to answer the first question: what is the most appropriate modality to be used in screening, and which modality should be used for complementary screening? In general, the female population is classified into an average risk individuals, moderate risk individuals, and high risk individuals. For the average and the moderate risk individuals, mammography is indicated for screening starting the age of 40, and it might be complemented with an ultrasound examination. For high risk individuals and for selected moderate risk ones, mammography together with MRI are indicated at a younger age, and it also might be complemented with an ultrasound examination. If we have 3D digital tomosynthesis, it should be used in screening in at least one view because it increases cancer detection, and in the same time it decreases the recall rates. While if we have contrast mammography has the potential to be used as a primary screening modality for high-risk individuals and for selected moderate risk ones instead of doing a mammogram and an MRI. While if we have ABIS, it has the potential to be used as a complementary screening modality in addition to mammography and instead of ultrasound. And we'll start by showing you some examples concerning the use of 3D digital tomosynthesis in screening.
Our first case is a 45-year-old average risk female, and this is her regular screening mammogram. Can you detect the abnormality in this mammogram, Rasha?
Yes, there's an evident circumscribed lesion in the right breast, but it looks benign, I think.
Yes, and by ultrasound, it was proved to be a fibroadenoma, and the ultrasound revealed the additional bilateral fibrocystic changes. Can you detect any other abnormality?
No, I'm not sure there's anything else.
When we applied the tomosynthesis, there was a speculated mass in the upper outer quadrant of the breast with a nearby enlarged intramammary lymph node, and the biopsy revealed an invasive lobular carcinoma. Our second case is a 48-year-old average risk female, and the regular screening mammogram revealed bilateral fatty breasts. What's the abnormality here?
Yes, there's a small nodular lesion here. It might be an intramammary lymph node, maybe.
Yes, it may be, but when we applied the tomosynthesis, this was not an innocent lesion. It's a speculated mass, and it was proved by biopsy to be an invasive duct carcinoma. The third case is a 54-year-old average risk patient, and she came for regular screening, and the mammogram revealed a focal asymmetry in the upper outer quadrant of the right breast for recall. And when we applied the tomosynthesis, this was an overlapping normal parenchyma, and no mass could be detected.
And what about the ABIS?
The ABIS is considered as a complementary screening tool in addition to mammography instead of ultrasound. and I'll show you some cases. This is a 50-year-old patient, high-risk patient, and what do you think about this mammogram?
I can hardly see these indeterminate microcalcifications in the right breast, but I'm not sure if they are bothersome or no.
Yes, when we applied the tomosynthesis, these microcalcifications are more evident, but still no mass could be detected. With the ABIS, both the coronal and the sagittal plane revealed an irregular mass, which was biopsied and proved to be an invasive duct carcinoma. This is a high-risk patient with a very strong family history of breast cancer, and the mammogram revealed a symmetrical density in the right breast, but no definite lesion could be detected. So the ABIS, when we did the ABIS, there were multiple small irregular-shaped masses at different positions in the right breast. To confirm this finding, contrast mammography was carried out, revealing multiple tiny enhancing foci, and the pathology revealed a multicentric invasive ductal carcinoma.
Yes, and so bringing us to contrast mammography, should it be used only on recall, or can we do a primary screening with contrast mammography?
I will show you some cases. This is a screening mammogram of a high-risk patient with a very strong family history of breast cancer. Do you detect the abnormality in this case?
Actually, there are multiple areas of concern, but which is the most suspicious, I'm not sure in respect to mammography.
With the contrast mammography, only the lesions in the lower inner quadrant of the breast were enhanced and proved to be a multifocal invasive duct carcinoma. And here is another patient. She has her screening mammogram at 2016, and the breasts are very dense, heterogeneously dense.
You know, based on this type of breast, I would consider her a moderate risk. And if she comes for me the next year, I will do a contrast mammogram directly.
Yes, we have did the contrast mammogram for this patient, and it was negative. No enhancement was detected. At 2017, the mammogram was carried out, and no interval time changes was detected, but with the contrast mammography, we started with the contrast mammography, and it showed subtle faint focal enhancement in the left inframammary fold, which confirmed by ultrasound to be a speculated mass, and this was biopsied and proved to be an invasive lobular carcinoma.
And now moving to the second question, when should we recommend for contrast mammography, and when should we recommend for tomosynthesis? Definitely mammography has been and still remains the first-line defense against breast cancer. But it's always accused of having a low sensitivity because the normal breast tissues might obscure an abnormality, and this is responsible for a large number of false negative results. It's also accused of having a low specificity because the superimposed breast tissues might give the impression of a false abnormality, and this is responsible for a large number of false positive results. These limitations were the motivations behind the efforts to upgrade existing mammography technologies and develop better ones, causing enhanced detection and diagnosis of breast cancer. Modalities which are affordable, fast, and in the same time applicable. And of course, on top of the list comes the 3D digital tomosynthesis and the contrast-enhanced mammography. To understand the difference between the tomosynthesis and the contrast-enhanced mammography, we all know that the best results in breast imaging are always obtained from imaging modalities which can provide both morphology assessment together with functional information. And when we look at tomosynthesis, we will find that it plays its major role in giving us an enhanced morphology assessment, but it has no role at all in giving us any functional information. And that's what makes the 3D digital tomosynthesis suitable to be used as a screening modality. While if we look at contrast mammography, it provides an enhanced morphology assessment together with some functional information obtained from the injection of contrast medium. And this makes contrast mammography more suitable in lesion characterization, in identification of multiplicity, and in the follow-up of patients receiving neoadjuvant chemotherapy and in the post-operative breast.
Now I will show you a case to which to choose, CSM or tomosynthesis in lesion characterization. This is a 70-year-old female with a newly developed palpable left breast mass lesion. She came to us at 2014, and this lesion was described as an intermediate lesion taking a ductal distribution with intermediate microcalcification. The patient refused biopsy. Next year, at 2015, the screening mammogram was carried for this patient, no time interval change, and with the tomosynthesis, the lesion became more evident but was still suspicious. With the contrast mammography, no enhancement was detected, and so this confirmed the benign nature of the lesion, which was a sequelae of periductal mastitis. Another case, 35-year-old female, which has a palpable left breast mass lesion, and the mammogram revealed a speculated mass, which became more evident with the tomosynthesis, but the ultrasound revealed a small, tiny, suspicious mass in the retroareolar region of the right breast, which cannot be detected by the mammogram or by the tomosynthesis. With the contrast mammography, a tiny focus enhancement was detected and the biopsy revealed bilateral invasive duct carcinoma.
And what about the post-operative one?
This is a case of left conservative breast surgery and with newly developed microcalcification at the operative bed. With the tomosynthesis, the microcalcifications become more evident but still suspicious, and with the contrast mammography, no enhancement was detected, which exclude tumor recurrence. And this was only operative bed fat necrosis.
And now moving to the third question, contrast mammography and MRI, which is right for whom and under what conditions? Both contrast mammography and MRI are used in the assessment of breast lesions, and both techniques have features in common. In both techniques, we use contrast agent to highlight areas of increased vascularization. Thus, they both supply some functional information about the tumor cells in addition to an enhanced morphology assessment. Yet both techniques also have different features. Contrast mammography is less time-consuming, better tolerated, and with a relatively lower cost than MRI. MRI is highly sensitive but requires longer time for imaging processing and interpretation and has a relatively low specificity. In contrast mammography, we have the advantage of assessing microcalcifications, and in MRI, we have the advantage of multiplanar and multi-sequential imaging, which allows for better lesion characterization. If you look at these features, we might say that contrast mammography can replace MRI in many conditions because it is cheaper, it is less time-consuming, easier to perform and to interpret, has comparable sensitivity and specificity to MRI with less background parenchymal enhancement, reducing the false results. But we have to admit that MRI still takes the upper hand in some selected clinical situations. For example, MRI is still superior if we use it as a diagnostic modality in lesions which occur in hidden mammography areas and in the inflammatory breast lesions. If we use it in staging, MRI is superior than mammography because we can assess the lymph node status. It is better in assessing the skin and the chest wall invasion. It is better in estimating the size of speculated lesions and the intraductal extension. It's also superior than contrast mammography in the follow-up in the immediate post-operative period where we get pathology reports with the positive margins. It's superior in assessing the mastectomy beds and in patients with breast implants. And if we look at both contrast mammography and MRI, up till now we are using the lexicon of morphology descriptors used in MRI. We use it in describing lesions in contrast mammography. And this is a good example. This patient had a bilateral breast lesions. If we look at the lesion on the right side, we can say it's a mass. This mass is oval, circumscribed, with dark internal septations, all features pointing to a benign pathology, and actually this was a fibroadenoma. While the lesion on the left, it's non-mass enhancement, it's asymmetrical, it's taking a regional distribution with a clump pattern, all descriptors pointing to a malignant pathology, and actually this was a malignant invasive duct carcinoma. And if we look at the MRI of the same patients, I think the same descriptors we used in contrast mammography apply for what we see on MRI.
This is a case of bilateral circumscribed mass lesions. What do you think, Rasha? Which is benign and which is malignant?
Actually, they look the same. One is rounded and one is oblong, but they look more or less the same. Yeah.
But in the contrast mammography, only the right breast mass is enhanced with a tiny enhancing focus seen anterior to it and non-mass enhancement detected in the retroareolar region. And this was a triple negative breast cancer, while the left breast mass was not enhanced and it was a small fibroadenoma. Also, MRI is superior in the evaluation of inflammatory breast lesions. In this mammogram, the only abnormality detected is the focal asymmetry in the upper outer quadrant of the left breast. With the contrast mammography, a mass lesion was detected, which is oval in shape with rim enhancement and anterior intraductal extension, and it was assigned as a malignant lesion by Radford. But with the MRI, this was simply a cavity, an abscess cavity with a bright T2 fluid signal and rim enhancement on the contrast study. And so this was an abscess cavity in granulomatous mastitis. Also, MRI has the upper hand in the evaluation of deeply seated lesions in the inframammary fold, upper inner quadrant, and in the axilla. This patient was presented to us with right upper inner with right breast lump, and the contrast mammography was free, no enhancement was detected, but with the ultrasound a malignant looking mass was detected corresponding to the site of the abnormal of the lump, and with the MRI the speculated mass was detected in the upper inner quadrant of the breast, showing rim enhancement. But contrast mammography is excellent in the detection of operative bed recurrence. In this patient with a left conservative breast surgery and newly developed left lower inner quadrant palpable lesion, with the CSM, focal enhancement was detected at the operative bed, so the contrast mammography can detect the operative bed recurrence and the newly developed lesion. With also MRI is superior in the evaluation of mastectomy bed, as in this patient with right mastectomy, a newly developed mass was detected at the operative bed, and in the MRI, the mass is seen infiltrating the anterior chest wall, reaching the pleura. Also, MRI is superior in the immediate post-operative period. Here is a patient with right conservative breast surgery with closed margin, and the mammography revealed operative bed scarring, while with the contrast mammography, irregular rim enhancement is detected at the operative bed with shaggy outline and misinterpreted as residual disease, but the biopsy revealed operative bed infected seroma.
Yes, but actually I have cases like this young individual where a pathology report came back with a positive margin, and she performed an ultrasound. There was an operative bed seroma, and the rest of her breast was extremely adenotic and no lesions were identified. We decided to perform a contrast mammography, and on contrast mammography the residual disease was very evident on her mammogram.
Okay.
And now moving to the last station, when do mammography and ultrasound still have an upper hand over modern diagnostic imaging techniques? I think they still have the upper hand, mammography, in the assessment of microcalcification and in identifying breast asymmetries from the start, and ultrasound still has the upper hand whenever we have young individuals, inflammatory breast lesions, and intraductal lesions.
Here is a high-risk 34-year-old female with past history of left mastectomy, and the mammogram revealed grooved microcalcification at 6 o'clock. These microcalcifications were seen by ultrasound and targeted for biopsy. With the contrast mammography, an extensive clumped segmental enhancement was detected implicating at the site of the microcalcifications, and this was proved to be a ductal carcinoma in situ. A patient with uni-orificial bleeding per left nipple, the mammogram revealed left breast nodular lesions having adductal distribution and are faintly enhanced on the contrast mammography. Rasha, can you tell me whether these lesions are intraductal or extraductal?
No, based on the mammography and the contrast, we can never say if they are intra or extraductal.
Yes,
in location.
I think that ultrasound is the imaging modality of choice for the detection of intraductal lesions, and this was a case of multiple papillomas.
And to end our lecture, in the last decade, we have witnessed an intense increase in the volume of breast imaging techniques with the development of new technologies and the upgraded applications of already existing ones. These new breast imaging technologies are meant to enhance the evaluation of patients with breast problems by ruling out the presence of breast cancer and in the same time addressing the patient's symptoms. Yet the challenge will always remain: how can we achieve this goal by using the right modality in the right time and for the right person? And thank you.
Thank you.